assistant professor here at Information School at UW, and I'm also a member of the Symposium Scientific Programming Committee. My background is in health informatics and natural language processing, for some context, and I work on developing language technologies and systems to solve problems around information accessibility and human AI collaboration in domains like healthcare. So we have a really great group of panelists, and I'm really excited to start this conversation. We have folks from the UW, from the Hutch, those with industry ties. And the theme of today's panel is ethical AI, but more broadly also just kind of the theme of today's symposium, which is ethical and inclusive data science and AI to improve health. So I want this to be useful to the audience. So as we go along, please continue to be active in chat, and we'll integrate those questions into the conversation. So I'm going to ask all of the panelists to briefly introduce themselves and describe how your work relates to the theme of today's symposium. And let's do this in the order I have on the symposium agenda. So can we start with Diane, please? Diane Korngiebel.
Hello. First of all, thank you all for having me here. It's really a privilege to come back to UW, even if it's snowed in. So I am Diane Korngiebel. I am a senior health ethicist and AI ethicist at Google. I work across the company, including health. I'm centered in trust and safety. And my work covers really a gamut of things, from tools that may be created in the health AI space to chatbots and how we communicate with users. I'll stop there.
Great. Jeff?
Hi, thanks for having me. My name is Jeff Leek. I'm at the Fred Hutch. I'm the Chief Data Officer and a professor in the Biostatistics program there. I lead teams that help develop data infrastructure and governance policies and support tools for helping people make use of data at the Fred Hutch, including in the development and deployment of AI models. Also lead the Cancer AI Alliance, which is a sort of national cancer AI effort. And my experience in the area is mostly as a person who listens to people like Diane and makes sure we try not to do the wrong things. So hand it off to the next person.
Yulia, would you like to introduce yourself?
Yeah, thank you for inviting me. I feel a little bit like an imposter because I don't have any medical background. I work on natural language processing and AI ethics. I'm an associate professor in Paul Allen School of Computer Science in UW. My research focuses on technical methods to mitigate risks of language models, to make them more useful, reliable, hallucinate less, be less biased, and be more explainable. And more recently, I started working on the medical applications in the intersection with AI ethics. Yeah, it's nice to be here. Yeah.
Thank you. And Andrew, please.
Yeah, sure. I'm a professor of medicine, and I'm an internal medicine hospitalist practicing at the University of Washington Medical Center. And I'm our assistant CCIO, Chief Clinical Information Officer for decision support, documentation, and I am one of the co-chairs along with Peter of our predictive analytics governance committee. I'm also a patient safety researcher and educator. I spend a lot of time working with both externally funded projects and then also with residents and fellows, trying to think about how to make our healthcare system safer. The principal activity that I've been involved in very heavily in the last year that I think relates to this panel is I've been a clinical lead for the implementation of several AI-based software platforms, either within Epic, our enterprise EHR at UW Medicine, or as third-party additions. So I've had to wrestle with some of the tough questions around how are we going to make these software tools work, both for patients and for clinicians in ways that are fair and ethically sound. So thanks for having me.
Great. Well, I'm super excited to have you all here. And maybe we can start with a more broad question. So what do you think of as some of the biggest promises and the biggest challenges for leveraging machine learning and AI in the spaces of medicine, public health, these kind of high expertise, high risk settings? And of course, this can be from your personal experience or just kind of thoughts that you have more broadly. If anyone wants to start, please go ahead.
Well, I can hop in, and since I've been actually sort of at the point of entry into the healthcare system for implementing some of the tools that have reached the point of being commercial products that a health system can deploy, and is having to, our health systems having to answer the question of what is that promise? Does it fulfill that promise? And where we're at really right now is looking at tools that improve clinician and system efficiency. So whether that's data gathering and summarization, we're deploying a platform called Evidently, which scours through records and attempts to assemble salient points in ways that haven't been done before by existing tools. Or documentation that speeds the workflow for clinicians. Just a few days ago, we turned on a Bridge, which again, a third-party vendor that helps to do ambient documentation, uses a lot of AI in its workflows. For some degree of enhanced communication, we've been using the in-basket automated response technology or ART that Epic provided. So these are sort of I would say, three of the less than the single digit number of AI tools that are active in our system right now, and they're all really they're again centered around clinician efficiency. I don't think that's not where the long-term promise solely lies, but that's what we're seeing right now, and it's exciting. That alone is promising, but I think there's a lot more. I don't want to drone on, but that's sort of a current snapshot. That the really immediate term promise, but I'll see if others want to weigh in about long-term promise, maybe.
I can go next.
Yeah, please.
Yeah, I think about related areas, maybe with a different order, and maybe it is related to the difference in background. I'm very excited about building AI technologies that can inform patients and inform users. So it's from aggregating knowledge across different disciplines, summarizing it, and also simplifying it. So providing really reliable, useful information, especially in languages and dialects where people don't have sufficient access to clinicians. So I'm very excited about this direction of just being useful to users. A second direction maybe in assisting clinicians. Here we talk a lot about assisting and not supplementing and not replacing, but there are many ways on how the AI can reduce cognitive load by summarizing notes and a lot of information, assisting in differential diagnosis to improve coverage. Or if, for example, a clinician have an expertise in one area, AI could we could develop agents to bring additional expertise across areas. And also building, for example, personalized educational assistance to train clinicians. So there are many, many different applications with different goals. And maybe the final direction is just AI for science. So how can we aggregate different types of knowledge and extract claims and help basically understand what are the gaps and what are interesting, promising future directions to just advance medical knowledge.
Yeah, maybe I'll comment. I think like Yulia, you just brought up a lot of these more kind of technologies that are like uses for these technologies that are still in development, that we are not yet deploying in health systems, in contrast to some of the things that Andrew was just talking about kind of improving clinical efficiency, maybe the more like low-hanging fruit. And I think this is making me think of a conversation in chat from the end of the last session around kind of current clinician workflows and some of the good parts and the bad parts of that, right? Like there are medical errors in clinical settings. So if we train these models to just reproduce or support current workflows, are we getting both the good parts and the bad parts of that, right? And this is beyond just medical errors, also things like enforcing current biases in healthcare and things like that. And maybe those are also some things that the other panelists would like to comment on.
I'm happy to jump in here. So as an ethicist, one thing I'm trained in is issue spotting. So of course, as I listen to the people who've been talking, I'm already thinking about, okay, what are the issues that I'm spotting? So when I think of clinical efficiency, I think, okay, great. Are clinicians really spending more time with patients, or are they taking on more patients? How do all of these things intersect with a third-party payer system? So that might be one thing that I would want to be considered upfront. And actually, maybe I should preface this with saying implementation is where the rubber hits the road. And that's when we're going to figure out what evaluation we need to do. Because we talk about all these things, we talk about hallucinations, we talk about fairness in data sets or unfairness in data sets, all these things that have to do with creating. The rubber hits the road when we see what the outcomes are for patients, for clinical workflows, for clinician time. And that's where we need to be figuring out how to measure things now, like right now. And I'll stop there because I could keep on going.
Yeah, I think maybe just to add, what everyone else said is very thoughtful. And I think for me, I sit somewhere at the sort of intersection of a couple of these things. A lot of the work that we're doing is enabling the development of new AI technologies as well as some implementation work. But the challenge has always been people. Even though there's these new technologies, they're exciting. The impact on people seems to be where the hardest parts are happening. It's both the challenges of creating those technologies and putting them in place are often an exercise in organizational work, but also the sort of measuring. I think Diane's point is very well articulated that it's incredibly important to measure the outcomes on both physicians, if you're talking about improving operational efficiency, but also on the patients. And are they comfortable having their information measured in that way? Are they comfortable with it being stored? Are they comfortable with that tool being turned on? What are the potential implications, again, for payers and things like that? So I do think that we're just at the beginning of implementing these technologies, and they're incredibly exciting. And I'm sort of an evangelist. I love these technologies, but I also am a realist in the sense that we're just beginning to measure their impacts. And that's where we have a lot of work left to do, is measuring how they impact the downstream groups of people that are using them or are having them used on them.
Yeah, maybe we could talk a little bit more about evaluation since we're on this theme. So it seems like there's a real disconnect between how the systems are evaluated prior to deployment and then kind of sometimes maybe even lacking an evaluation plan afterwards, or maybe there is an evaluation plan, but how do we adjust that to really account for the real world implementation challenges? So maybe I can ask you all to comment on what are some strategies that we should be thinking of when we think about deploying these technologies in real world settings?
If I can temporarily redirect to one side comment, which is that that's absolutely nothing new. So our country and many other countries have failed for decades to appropriately fund health services research, comparative effectiveness research. So the challenges that we're facing with this technology, we've witnessed in prior decades with many other novel technologies. I think this is of a sort of scope, scale, and consequence that's quite a bit above what we might have seen with past either IT or pharmaceutical introductions into medicine. But for a super long time, we've done a bad job as an industry, as a profession, and as a country of figuring out how to deliver the best care in a systematic way. So this is just nothing new. We've always had this problem, and hopefully the sort of the scale of the challenges and the consequences will galvanize a little bit more action. But it's hard to say that this will be any different from past times when we've had technologic change and not known how best to use it or how to measure it as it's implemented, and rapid uptake in many health systems proceeds without either local measurement or distributed measurement in a really rigorous and academic way. Anyhow, so I didn't answer your question, but I think I just want to sort of situate this in a bigger, I think, challenge in healthcare is that things do get deployed without adequate evidence all the time.
Can I also add something? Yeah, I'm furthest away, I think, from deployment, and it's a relief for me because we work on research, and maybe because I understand how poor language models are at reasoning, despite seeing very impressive publications on superhuman performance. I would be terrified to deploy a language model in any real-world setting right now. And in addition to just evaluation of these reasoning abilities, the conflict that I'm grappling with is this trade-off between just people's agency and privacy and personalization. Because like the more reliable we want the model be, the more personalized this should be. But then they would make decisions about like what you need and how you need, and also would use all of your information, and also they would spit other people's information. And figuring out how to kind of make them both safe and preserve user agency, but also personalized and reliable, to my knowledge, they're very, very far from deployment even in kind of very resource-rich domains.
If I could bounce off of something that Andrew said, and also Yulia. So Andrew, you mentioned local evaluation as one of the ways that we do this. And then Yulia, you brought up the whole issue around privacy. So I'm becoming a great proponent of, and Peter's already heard this before, so Pache, Peter, of local policies that are enacted by the healthcare systems, policies for how these AI tools can be used, will be used, what your benchmarks will be, and then a plan to revisit those benchmarks and test against them. And they need to be updated, just like clinical practice guidelines need to be regularly revisited and updated. This will need a task force. I could think of a whole bunch of things that will be necessary to do this. But if you start it now, then you will be getting close to being ahead of the curve when regulation catches up. And it will catch up eventually. I don't know if that will be 2 or 20 years, but it will catch up. So that would be something I would strongly suggest people to start thinking about. And don't forget your ethicists.
Anyone else like to comment on that? I think I strongly support this kind of thinking about the outcomes in advance. It's a hard challenge, right? Because there's also going to be things that come up during implementation that were unexpected. But if we have a team of people that's sort of designed to deal with those challenges as they come up, I agree we're in a better place. So maybe kind of another question I have here, and also just a comment to the audience. If you have questions, please feel free to put those into chat, and I will look over those. But speaking of ethical principles versus regulatory requirements, right? So we have kind of norms versus law or regulation. What are what do you think are the criteria for these health AI systems to ensure that they kind of comply with both norms and regulation, and kind of where is that line that we should put between norms and regulation?
If it's okay, if I could just make a couple overarching comments here. So once again, speaking as an ethicist, the regulations, the law, the compliance, that is the baseline, right? That's like what we have to hit to be, legal. Ethics is also aspirational. What do we want to achieve? Who do we want to be? And I think that there is a tension between the two, but I feel that it can be tempted to conflate the two, and we must resist that. I can keep going on ethics if you want me to.
I think I would say that as a person who has to sort of pay attention to this for tools that we implement or technologies that we use, the challenge has been that the regulation, to the point of, is it going to be in 2 years or 20? It seemed like it's been as fast in terms of the regulatory change in some sense as in some components of the regulatory change as it has been in the technological shift. There's been new laws, especially around data and from different states have different regulations. Nationally, we have different regulations. There's a set of executive orders that came out about AI not too long ago. Now it's unclear if those apply. It's sort of, I would say it's a tricky place to be in terms of the regulation at the moment. And so I think then to the point of the ethics being aspirational, I think it helps to avoid some of the challenges of the regulations being shifting. If you target the aspirational ethical use of that data where you have some tenets that you sort of agree to and maybe validate with different stakeholders, whether those are patients or providers or so forth. And then being careful to try to stay within the scope of the laws as they are, but it's tough if you have different regulations and you're seeing patients from 3 different states, and those 3 different states have different data and technology regulations. It gets a little tricky to thread that needle. And so I don't envy the folks that have to do this. And it's the thing that's been so interesting to me is to do this successfully. It's a multidisciplinary approach. I think you really need people who have different kinds of expertise in the room to have any chance of having success. It can't just be the technologists or the AI people. It has to be, ethicists, legal folks from compliance, et cetera, all have to kind of weigh in. So, and that makes it harder and slower. So that part is all slower than the speed with which the technology is going. And that's very frustrating because you want to go as fast as the technology, and none of that other stuff is fast. And so it's sort of, I don't know. I'll just say that makes me frustrated, that it's like you can't keep the speeds to match each other for those two things. But it's super important.
I'll pick up on something that Diane mentioned earlier around clinicians and the effect of AI implementation on their work life. And I think that this is a potential spot where regulation is largely, I expect, I mean, I'm not an expert on every regulation. As Jeff brought up, it's rapidly changing. Things we knew to be true a month ago may be totally wrong in the next 6 months. But by and large, I expect regulation to be focused principally on the needs of patients and the public at large, and not explicitly written for the workers in healthcare systems. Because so many of us have, certainly in the physician population, but then for a very long time preceding that in other health professions, have been employed by large employers increasingly, we're our relationship with the deployment, or rather the relationship that matters, that governs that deployment of AI, is really between clinicians as employees and large healthcare institutions. And that may fall well outside the bounds of a lot of regulation. It may be subject in some cases to the influence of unions, but in a lot of cases, it'll be a topic for really things like professional self-regulation and frankly, the ethical conduct as determined by the institution itself. And what Diane brought up is, are we, for example, if we give clinicians access to a tool that makes them more efficient, are we just going to say, now you just need to see a lot more patients to pay for this? Or good news, this is actually going to enhance your well-being. You're going to have more time to spend with patients. That has an enormous effect on the well-being of those clinicians. But again, that concern is going to fall outside of regulation, and it's going to fall to the ethical conduct and decision-making of institutions to decide how much to prioritize the potential financial capture of a system that improves efficiency over its effect on clinicians who you could make just as harried as they were before. So I see this as a real important area that you do need to stake out those principles in advance and try to hew to them as much as possible, because it's not going to be something we could see through regulation, most likely.
Would anyone like to respond to that? Yulia?
I can just quickly add, yeah, because, sorry, I just don't see when I am unmuted. I wanted to just agree with what Diane said, that regulation sets the minimum standard while ethics sets the maximum standard and aspiration. And at least from, again, from a totally different perspective of a developer of technology, I feel user agency, what I mentioned also earlier, is extremely important, and also building technologies that are culturally informed towards the aspiration, basically, not only the regulation.
Okay, I'm going to ask a question from the chat. There's a few interesting comments and questions around the relationship between transparency and ethics as a whole, and kind of the impacts, or like kind of thinking about downstream users, whether that be clinicians or patients. How do I phrase this question? I guess, is there is there a case where the deployment of AI could be ethical without transparency, right? Like without fully informing all the kind of users or the people impacted by the technology that, for example, their data is being used, or that the model's making predictions on their outcomes. So is there this relationship between transparency and ethical AI? Is transparency like a necessary component of ethical AI in all settings?
I would lean toward yes, if I'm given a continuum versus no. Some of you may already have heard me present on T, transparency, engagement, and accountability. And I think those are very important in the AI and health and healthcare administration space. And so for transparency, I talked about having those local policies. Those policies should be able to be shared with your patient base. And that may mean they are redrafted to make sense, but they should be shared. So you should know if your data is being used, how it's being used. There should be an explanation of what the heck AI is. We all have very different ways of framing that. That having been said, machine learning is nothing new, and we're just using this term AI now for something we've had for a while for certain types of, data prediction. So revisit how you've been thinking about decision support in the past. Were there things there that you felt you didn't really have to talk to the patient about? I don't know if that could be informative or not, but some of the issues aren't new, right? Some of them are, and some of them are certainly at larger scale, but some of the issues aren't new.
I'll try to be controversial and bring a different perspective. We don't know how to explain model decisions very often, and we don't know also how to explain the whole pipeline of how AI is used in a way that we are sure that the user would understand. And if you ask them, would they still want to have a more reliable diagnosis, even if we don't know how to explain it, they might prefer that. So I'm not 100% sure that we can kind of have a perfect transparency. And I'm not sure we should wait until we have it, until we
Oh, no, I wouldn't say that either. I mean, we've had aspirin since the 1970s, and we still don't necessarily know all the biological mechanisms that underpin it, but we can see the effects, right? And so that helps us make a judgment call. So I agree with you. I think there's this middle space. But once again, it requires consensus and stakeholders and engagement.
So we didn't manage to be entirely controversial. Okay.
One of the things that's helped me think about some of these challenges is like in transparency is to like for AI, the definition or the way that we think about AI, we've tried to simplify a little bit and say it's like three things. There's the data that goes into the model, there's the model itself, and there's the interface to the patient or provider or whatever. And so those are the three parts of any kind of AI tool. Can you? Oh, that's maybe somebody else. So, and so for each of those, we can kind of think about what does transparency look like. I'm not sure that.
Peter, could you mute yourself, please? Thank
you. So we sort of think about transparency and how a patient's data is used. Like, is it going to an outside company? Is it staying internal to the Hutch, et cetera? We think about transparency in the interface that the person has to that AI. Like, if you're recording them, is it hidden in the wall, or is it something that you put in front of them so they can see it? And then sort of transparency in what the model is doing. And that's the hardest one often because so many of the new models especially are pretty difficult to interpret what is actually going on under the hood. But trying to think about whether it's a version of a model card where you can explain at least at a high level what the model is doing. So sort of trying to be transparent in each of the aspects and making decisions about each of the aspects somewhat independently, because even if a model is pretty unexplainable, if the data all stays internal so it never leaves and the model has good outcomes and the interface is very transparent to the patient, that might be okay versus a case where you're, doing something different. And so that framework has sort of been helpful for us in thinking about these kinds of problems.
I'll quickly mention that one of the projects that we had to undertake just in the last couple of months, sort of on short notice, is the Office of the National Coordinator, the ONC, which helps to provide policy guidance for implementation of EHRs and has done so for more than a decade in the US. They released a rule just about 4 or 5 months ago that we had to comply with by January 1st that required us to demonstrate for any predictive model that we have within our system what they called sort of in federal language the source attributes, but effectively this was basically who was used in the training data set for the model. What do we know about the performance of the model? What do we know about who paid for it and where it's been tested? And the fundamental regulation here is just that information, those 5 or 6 facts, and maybe a little bit more, I'm sort of summarizing it briefly, that has to be available to clinicians. So this is a form of transparency that maybe is not, it's very indirect in terms of its availability to patients, but at least that physicians, nurses who are being exposed to decision support that is coming through predictive models, whether they be older machine learning or newer LLM based, that we have to know something about that model, its performance, and kind of who stands to gain from us using that in a sense. And that ought to be available to us. So it's a form of transparency that's fairly rudimentary, but now is the law of the land. In order to have a certified EHR, it's something that you have to have access to. I have my doubts about how often. So we went all over our EHR and we put links in many different places to websites that host this information, and did a ton of work to kind of prepare this. We're going to track how often clinicians actually click on these links to explore this information. I'm sort of I'm imagining that it doesn't happen very often, really, in the life of a busy clinician. But I think it's an important form of transparency to raise here, and it is a result of regulation, kind of tying into our prior theme. So there are ways that we can provide that foundation, right? Like the minimum piece of transparency is as a widespread good, and then hopefully build from there.
I feel like a theme that's emerging in this conversation is also that transparency alone maybe isn't very useful without some form of agency or way of impacting the use of the technology or whether it's applied to someone. So, I mean, like just telling someone how whether that their data is being included is not very useful if they can't opt out of it, or just telling someone that they're being recorded in the wall without being able to not be recorded, I think also isn't a very kind of useful form of transparency. But maybe we can, I feel like there's some relationship between this and model interpretability as well. I think in several of your responses, there's this idea of kind of like more interpretable models versus the kind of more the current versions of the powerful generative models where we're not confident that we can associate their outputs to inputs in the same way as before. And also based on a lot of our pilot award presentations this morning, it seems that interpretability is still really important in these clinical use cases. In these settings, where we don't necessarily have very interpretable clinical machine learning models, is there an impact on like who's responsible for the decisions of these models? Like essentially, if we can't explain why the model makes a certain decision and we're relying on them to assist in decisions, who's responsible for those decisions and who should be liable for those decisions? Open floor if anyone wants to comment.
Well, I don't. None of us are lawyers, right? Is this?
Yeah, I was going to say, I'm not a lawyer. Was my first line.
Yeah. I mean, I'll tell you as a physician how I would regard this. That I'm ultimate, and I feel confident enough to say this unless something radically changes about health law in the U.S. In the next decade. That if I'm implementing a decision that is informed by a machine, I nonetheless am fully responsible for it. There's no liability that I expect to pass to some other party, my institution, or the developer of that. Now, there may be people who would attempt to sue all those parties in an event of harm, but I would expect that I would always behave clinically as if I'm liable for the decisions that I make, regardless of whether I'm basing it 5% or 100% on the information that's coming from a machine. And I think that'll be the sort of the expectation going forward. Sorry, Seattle Public Schools is on snow day today, so I'm apparently in the way of the printer.
Maybe I can also. Oh, Diane, please go first.
I was just going to say, I that resonates so much with me, Andrew. Thank you so much. Very well put. And you raise an important point also in the chat, I believe, about thinking about certain elements as tools. And we have to think about these AI tools. And we keep using this language about them thinking or them collaborating or being an assistant. No, 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 no. They are tools. We use tools. And I think that just the reframing is very much needed, not least because some of the questions I saw in the chat when Eric was presenting had to do with trust. And who will trust these tools? And how do we make people trust these tools? And if we keep making them seem like they're superhumans or humans, then we're leaning into something we maybe should not lean into, because the clinicians are the humans. They're the ones who make the eye contact. They're the ones that touch, listen, communicate, right? And artificial intelligence is artificial. It is not intelligent, and it has no thoughts.
I don't have an answer who is responsible. I'm teaching AI ethics, and I have many similar polls when I present, for example, a self-driving car accident, and we discuss the question of responsibility. And we come up with that kind of, we cannot put responsibility on tools, but also we cannot put the whole responsibility on the user. And I think decision about responsibility should at least be guided by ethical frameworks, because depending on the known framework that you would use, the answer would be very different. So thinking about responsibility in the context of a deontological framework, I think would be very useful to come up with a better set of regulations.
Great. Thank you for those responses. Seems like a very kind of still lots of conversation to be had on this point. So there's a question in chat from Jason Lau. When policies and regulation can only go so far, what are ways to encourage an open dialogue for patients and frontline workers, as well as leadership commitment to evaluate the ethical impacts of AI? So how do we encourage dialogue about these topics? If anyone, feel free to comment.
I can mention an example, if that would be okay. So I would recommend we engage, right? We actually engage with our stakeholders, including communities, including those who have not had the best experiences with the healthcare system anyway. Identifiable communities. You need to talk to the people you purport to help, to serve. And one example is I recently visited a health organization on a reservation to talk with their health leaders about how they thought about AI and its potential uses. And I was expecting to get a lot of no interest at all. And what I got instead was really surprising. They said, actually, you know what? We're open to this because we think clinicians are biased. And if the AI makes a recommendation and the clinician overrides it, then maybe that clinician has to document their rationale for overriding that recommendation. And I'm not saying I'm not making any point about that, except that I wasn't expecting to hear that.
Go ahead, Jeff.
Yeah, I was just going to say an example from just kind of building on that from the Hutch is that we have a precision oncology initiative, the Stuart and Molly Sloan Precision Oncology Initiative at the Fred Hutch, and it has a community advisory board that's made up of community members who are cancer survivors, cancer care support family members, and so forth. And it's been really thoughtfully put together and has a real impact on the decisions that precision oncology program is making. And so I have been really impressed. This is speaking about Pete Nelson and Eric Collison and other folks over in the precision oncology group, but they've done a really good job of creating a forum to educate about the choices that are being made, including in pretty technical areas. I mean, precision oncology is at this intersection of machine learning and often pretty complicated genetic and genomic and imaging assays. And so they do a great job of sort of education and then soliciting real feedback and trying to adapt based on that. And so I really like that model and think that it could be useful. It's clear that it can be done well, even for quite technical areas, to engage a broader audience in that conversation. But it takes work and investment to do it. They've put a huge amount of effort into it. And so I think that's one way to engage those groups. I also think forums like this are a good place to have the fact that these conversations are being had in public and that we're talking about them and you have different people from different backgrounds talking about it, I think helps inform bigger decisions by leadership. This is a bigger group that can kind of go out and talk to all of their leaders, and that kind of spreads the word about these kinds of things. So those both feel like good, positive things we can do.
All right, great. I'd love to kind of ask a somewhat on a different topic. I guess, we have covered or started talking about things around, for example, health equity. But last question from me to you is, how do you think AI could be leveraged to help improve health equity for people who either are being kind of, right, like someone talked about physician bias. I think maybe Diane, you brought up physician bias that was mentioned by that community organization. There's physician bias, there's also model bias. Like, how can we account for these things while aiming to improve health outcomes for certain groups that we know experience worse health outcomes? Yeah.
I can maybe give a couple examples from my research. I'm thinking a lot specifically about this question on how to make large language models accessible to broader populations, especially disadvantaged populations. And the directions for research that we're now taking, one is building large language models specialized in informing users about women's health. So this is one example that was historically under-researched and underfunded, where knowledge is changing constantly. And also topics of discussions such as menopause, they are taboo topics. You would not see a lot of discussions on that, even on social media. So, and this would lead, for example, for AI also to be biased and hallucinate more specifically on those topics where they already in the systems, the equity is kind of imbalanced. So this is specifically what we are trying to improve, looking at topics which had received less attention in medical research and specifically improving them, aggregating more reliable knowledge in those areas. And another similar direction is building the same type of models for African languages, for dialects, because we all assume that AI works, but it works well for newspaper English. If we look at African American dialect and try to interact with the language model in this dialect or in African languages or in Indian languages, we would see like huge degradation in performance. And this is typically users who would need more of such information. So I think, at least in our direction, to improve equity from AI building perspective, we are looking specifically at who would benefit from this technology more, where the data is less reliable or less available.
Yeah, thank you for that comment. And I think it also relates to, so Kate Glasgow in the chat has a few comments around these kind of obstacles to care that certain groups face, like whether due to like linguistic barriers of the type that you were just mentioning, Yulia, or maybe racial biases, things like that. And in some ways, those groups of people could also stand to benefit the most from some of these technologies as well, right? Like if they're currently being underserved. So I think there's this kind of funny balance where maybe those groups are not being served as well by the technologies, even though they could potentially benefit more from those technologies. Would anyone else like to comment on health equity and how we could help improve health equity?
Well, I'll just add a risk. I don't think that this is a problem to be solved, but I think back to the topic of assessment, large healthcare systems, both for-profit and academic, are going to, I think, excel at the assessment of deploying new technologies, particularly, well, excel maybe they're going to be they're going to achieve it sooner and better than healthcare systems that have fewer resources or are smaller. And so that has a trickle-down effect to the patients they serve. It wouldn't surprise me if by and large, the rural or safety net locations that may struggle to assess the value of and the efficacy of AI implementation are also going to serve the patients who have difficulty with access and are have worse health outcomes to start with. So this is going to compound that. So I think one of the things that we need to do as a professional community is, when we assess something rigorously, we need to publish it. We need to find ways to assess it across settings to find out if it's works in a both in a urban well-funded healthcare system and in a far-flung less well-funded system, and we need those assessments to be available to all, because I don't think that we can rely on local assessment as the sole way to determine where AI works. And so that's really it's an equity topic, but it's sort of in our collective hands to decide how we want to approach assessment. Is it a selfish thing we do for our own business interests, or is it a collective thing that we do for the better good? I'd obviously argue for the latter.
Yeah, I mean, I think that it's this has historically always been the case, but policy and a lot of these kind of public health decisions are really inextricably linked, and we're kind of in a time when policy communication around these topics is changing really quickly. Right, like pre this year, the CDC came out with public statements like racism is a public health problem, but we don't really have like a lot of that is being walked back, and I think it's really hard as researchers working in the space around health equity to navigate the like the changing climate around these subjects. But I think I like what Andrew said. I think that resonates with us. Like, what are we trying to do as a part of the community around these technologies? And how much responsibility do we have as researchers or practitioners to push those agenda points forward? So we are we ran over our original time, and I appreciate you all for sticking with me here. I think if anyone else has any final questions, now is your moment. Otherwise, I might ask all of our panelists to just end with some last thoughts about the future of AI in health, ethical AI, whether you think things are trending up or down, what are the concerns, what are we forgetting about, and take a few minutes, each of you. I would love to hear what's on your mind that maybe we haven't discussed. Maybe we can start with, I'll start in order. So maybe Jeff, if you'd like to start.
Sure. I think whether is it trending up or trending down, I think probably, the future is already here, but it's not evenly distributed. So it's probably different places. It's trending up and down and sideways. I would say that I'm quite excited about what's possible with AI, and also think that Andrew made a very important point, which is this is not, and Diane made this point too, that it's sort of, these are technologies, these are tools, just like many tools we've had before, and we have to figure out how to adopt them and use them and evaluate them well. And that's not always been funded super well. So thinking about how to systematically both implement tools, develop tools, but also evaluate them and share that knowledge with people generally, and thinking through how the humans are the key part of the process is where I think the most interesting problems are. And certainly I'm excited about the work we're doing at the Hutch and the work we're doing in collaboration with UW and our other partners around how do we do that well? How do we sort of not only implement things, but evaluate them and share that knowledge with the world? I think that's one of the exciting things about being at a place that's academic and sort of focused on trying to figure these problems out, because some of them are pretty tricky. So I think it's both exciting and lots of hard problems for smart people to tackle from multiple different fields. Probably where I would say my head is at with respect to AI and at the moment.
Thank you. Andrew, any final thoughts?
Sure. I guess my biggest hope for AI is that it may be one of the few and most impactful interventions in a long time that has the potential to lower healthcare costs. So we're pretty accustomed to technology being accretive, meaning like a pharmaceutical company comes out with a drug, and then they come out with another one that's more expensive, and you use that with the first drug, right? We add things. We rarely deploy things that are considerably less expensive. A lot of this has to do with sort of what's commercially incentivized and what's paid for by payers. It's not to say that there aren't pressures to rein in costs or to be good stewards of resources, but it's pretty rare that something as transformative and broad as AI comes along in healthcare. And so I don't know this will happen, and I know that AI consumes a lot of electricity and computer chips, and that all costs money. But I think those costs are likely to come down and to become not a barrier to using the amount of AI it's going to take us to deliver healthcare in a way that we hurt fewer patients, we help them through our systems faster, we explain things better, and we start to finally address some of the things that make healthcare so punishingly expensive in the US. And I don't know when that cost curve will bend, but that is my That is my ultimate hope for what we're doing at a societal level, because that's in a lot of ways really the root of, or it's an amplifier for inequities, and for poor outcomes, and so hopefully this is part of the way forward there.
Get that. Yulia, please.
I'm also, like others, very, very optimistic and excited. When I started working on language models, I did it because I'm fascinated by human language and human communication. And I couldn't even dream on building actual tools that could actually help someone in the real world. So I feel very grateful to being able to develop technologies that would actually improve equity, would actually help someone. And I'm very optimistic also about AI for science, developing actually models that could advance human knowledge and improve also our understanding of things that we don't understand today. My optimism is a little tainted by the fact that all of this panel would be banned if we just use the keyword list that is currently used to prevent funding from NSF and NIH on topics that I personally really care about. But I hope it's something very temporary, and I hope the excitement will stay and the concern will go away very quickly. Thank you.
And then Diane, please, if you could close us out.
So yes. So I have a few thoughts. I too am cautiously optimistic about AI, both in healthcare, but also in addressing health equity gaps by providing information to people who may not have access to care. Like they may use a search engine, for example. I do want to touch briefly upon what Yulia alluded to. We are all in positions where we have a moment to meet. We will have future moments to meet too, but we have a moment to meet, and how well we do at addressing inequities and health and healthcare disparities also has to do with how we meet the moment. And one thing that I think of when I think about this, because if I keep reading Kate's question in the chat, I will be overwhelmed with despair. So I think about the zone of control and what it is I can truly affect change. Where can I actually affect change? And we all have zones of control. And it doesn't solve everything, but it's a place to start.
I guess thank you for the comments. I think it's a good note to end on. There's lots of challenges ahead of us, but we are also the ones that are empowered to do something about those challenges. So I just really want to thank everyone on this panel. Thank you for your flexibility. I'm bummed that we could not be in person together. Feel free to continue these conversations and chat if you have the bandwidth. And again, it's been great. And I look forward to the rest of the programming. Thank you.